ربنا يحسن الامور بقى يا فندم، احنا بقى لنا سنه يعني الدنيا قافله خالص يعني.
عايزين بقى الدنيا تفتح
يا رب يا
كمان
رب.
كارانتين في السفر وترجع.
في كندا برضو حضرتك في الدخول في كارانتين؟
كارانتين
اسبوعين اسبوعين يا فندم ولا قد ايه؟
أسبوعين. اه
اسبوعين زي انجلترا بالظبط.
اه فأنا اضطريت أجي مصر مرتين. فعملت كارانتين أسبوعين، شهر ضاع.
اه طبعا مشكله، هتخلي السفر صعب قوي بالنسبه للدخول تاني. كان امريكا بتهيألي مفيش كارانتين لسه،
مش عارف،
مفتوحه لسه يعني.
ما بيدققوش أوي زي كندا.
ما بيدققوش قوي زي كندا وانجلترا بالظبط.
لا، الكارانتين متعب، وبالذات تاني مرة بالنسبة لي يعني. بيلوز فتنس كتير.
كارانتين ايه؟ ما تخرجش من البيت يا فندم؟
ما تخرجش من البيت خالص.
أصل في انجلترا ممكن كارانتين، بس ممكن تخرج مثلا تعمل شوبينج معين بسريع بسريع كده يعني.
اه
انما ده مفيش خروج خالص.
لا، ما فيش خالص. في غرامات كتيرة وسجن.
مم.
عاملينه سيريس. في ناس بتخرج طبعا، بس هو نصيبه.
لا 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 لا، صعب صعب.
ده
صعب.
صعب.
انا يعني الواحد ما سافرش اي حته بصراحه من شهر اتنين ما فيش اي حاجه يعني.
لا، احسن.
وكل المؤتمرات كانسلد يعني، ايفن لاول مره في تاريخ الامريكان اكاديمي كانسل الامريكان اكاديمي.
صح
يبقى يعني دي حاجه ان ريبورتد قبل كده يعني.
صح. اه ولا بيدياتريك اورثوبيك سوسايتي السنه اللي فاتت اتعملت اونلاين.
كله اونلاين كله اونلاين.
كنديان اورثوبيك اسوسيشن اتعمل اونلاين. السنه دي هنعمله اونلاين برضه.
اي ثينك سو يعني، اي ثينك لاخر السنه برضو يعني. اي ثينك ان كل حاجه تبقى اونلاين برضو.
هي بيدياتريك اورثوبيك سوسايتي قالوا هيعملوها في تكساس ان بيرسون. فما اعرفش بقى، هو في ماي. مش
ما
عارف
مش
بقى باي
هيلحقوا مش
ماي
هيلحقوا.
هنلحق ولا لا.
اعتقد صعب شويه.
صعب جدا. مش عارف. ما حجزتش،
لسه.
ما رضيتش اسجل
بس
ولا
هم
حاجه.
سعادتك بيعملوا في الحجز بيدوا يعني بيدوا فلكسبيليتي شويه في الحجز، ان حضرتك ممكن تلغي لحد قبلها، تكنسل لحد قبلها باسبوع او حاجه زي كده.
صح. اه
فهي دي حاجه كويسه بصراحه.
اه ده كويس. انا اعتقد ما فيش داعي اروح السنه دي.
وتكساس بعيد عن حضرتك قوي، ده في الجنوب خالص.
تكساس بعيده والسنه دي قلق كده، لسه ما حدش
لا
عارف.
لسه، لا 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 لسه
مفيش
ديفنتلي
حاجه
لسه
واضحه.
يعني.
اه
بس اي ثينك ان عندكم الامور مش سو باد زي امريكا يا فندم.
لا، احسن كتير. هما
اه
الميزه ان هم قفلوا الحدود من البدايه.
ريستريكشنز جامده قوي في كندا.
اه الطيران مفتوح شويه، بس طبعا قل.
تمام طبعا
آه
definitely.
البري very very restricted.
تمام تمام.
خاصة إن إحنا كمان جنب نيويورك ستيت. تلات أرباع
اه
ساعة من هنا كان كل البهدلة هناك زي ما بيقولوا.
نيويورك مبهدله خالص.
آه
وبعدين الانشورنس عندكم في كندا احسن بكتير من امريكا يا دكتور وليد بيه. يعني اي ثينك ان الهول بوبيوليشن انشورد في كندا
هو كل الناس انشورد في كندا.
عكس امريكا.
هي بابليك انشورنس، مفيش برايفت في كندا. ده يعني شوية اتس جود طبعا للناس، بس عيوبه حاجتين: الويت ليست فيري لونج،
تمام.
والعيب التاني ما صعب جدا نجيب ناس من بره، نعالج ناس بره من بره كندا. في بعض البروجرامز بسيطة كده فاتحة الموضوع ده ببرميشن. بس احنا في ناس كتير بتطلب تيجي تتعالج هنا. صعب. ماي ويت ليست مثلا 3 سنين. طبعا
اه
صعب تجيب حد برايفت
بالظبط
تعمله، وفي ناس تانية في الانتظار. دي بس
بالظبط.
العيوب، انما غير كده فير سيستم للناس كلها.
يس.
ما تقدرش تجيب حد قبل حد. الويت ليست ده اللي محتاج تظبيط.
عشان
محتاجين
كده
ده.
سعادتك يا فندم فعلا يعني كندا ملهاش سمعه عاليه قوي في موضوع علاج حد من بره.
عشان ما فيش
بعكس
برايفت.
مثلا فرنسا وانجلترا وامريكا، عشان ما فيش برايفت صح.
بالظبط.
رغم ان الطب فيها متقدم جدا بس ملهاش سمعه في المجال ده.
يا دوب بس
هي
للناس
بتكفي
اللي
الناس
موجوده.
بتوعها.
واتس مور ذان انف يعني.
بالظبط. حتى
مش
السوشيال ليفل هناك اكتر من امريكا بكتير
yeah.
واحسن بكتير.
yeah. امريكا بقى بيزد على الانشورنس للاسف. في برايفت كتير. ففي
تمام.
ناس مظلومه في الموضوع ده. اللي عنده انشورنس it's a good service. They have a very good system. بس مش لكل الناس.
بالظبط كده. يعني احنا we are ready to start يا فندم.
تمام.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. طبعا النهارده يسعدنا ويشرفنا وجود أخ عزيز صديق حبيب فاضل أستاذ دكتور وليد بيه قشطة، جامعة ماكماستر يونيفرسيتي، بروفيسور اوف اورثوبيديك سيرجري بيدياتريك اورثوبيديك سيرجري ماكماستر يونيفرسيتي كندا. دكتور وليد بيه بيشرفنا النهارده بمحاضرتين في غاية الروعة زي ما عودنا. اول محاضره استاذنا دكتور وليد بيه هيتكلم عن الهيب اوستيوتوميز، وتاني محاضره هتبقى على النيك لينثنينج اوستيوتومي. فطبعا دكتور وليد بيه مشكورا هيبقى معانا السهره النهارده ونشرف بوجوده معانا. You are very welcome sir.
ألف شكر دكتور محمد. وأنا يعني يسعدني دايما إن أنا أبقى مع بنها ودكتور محمد، يعني عمل very impressive work during this year. So we have a long day, two big lectures. We'll talk first about the hip osteotomies or the pelvic osteotomies. I would say pelvic osteotomies. I will focus on this. And it's interesting that we do the pelvic osteotomies from day one. So I will show you some indications that we can do pelvic osteotomies from day one. Before we go through this, I would like to say pediatric orthopedics needs a focused training. So we'll review all of these things, but I would just focus on saying these things need a fellowship or a center that doing pediatric orthopedic. Because it's not only about the osteotomy, it's a full planning. And as you know, like for example, the DDH has different stages of treatment based on the age. 0 to 6 months has different treatment, 6 months to walking age, different treatment, walking age is different, adolescence is different. So it needs a treatment, it needs a training, specific centers that deal with this.
So, I'm sorry, Dr. Waleed, I think the slides are not running.
Yes. I haven't started.
Okay, thank you. I'm sorry, sir.
So, first thing I'll talk about the imaging. For hip dysplasia or for Perthes disease or for any hip imaging, you need to focus on three things. Number one, the acetabular side. Number two, the femoral side. And number three, both of them. Always comment, document all of these during the follow-up. Acetabular side, we look at the acetabular index. And I'm very sure all you know how to draw the acetabular index, a midline at the Helger-Rhinal line, bisecting the triradiate cartilage, and then you get the index with the angle from the triradiate on this line to the tip of the acetabular. Acetabular index of sharp for older kids with closed triradiate cartilage. Acetabular depth, you can eyeball this, or there are some new studies for how to measure the acetabular depth. And I'm very sure the people doing arthroplasty, they have their tools. Look at the sourcil, because this is a weight bearing, and also look at the teardrop. And I'll tell you, the teardrop is a very important sign to tell you, is this a developmental dysplasia or this is early onset dysplasia or late onset dysplasia. If it's late onset dysplasia, like in neuromuscular condition, Charcot-Marie tooth, you know, it's 10 to 15% can have a secondary acetabular dysplasia. And if you look at the teardrop, you will find it well developed compared to someone born with DDH and they didn't get the chance to develop the teardrop on the X-ray. Femoral side, as you know, look at the neck shaft angle, look at the Helger-Rhinal epiphyseal angle, if the epiphysis is still open. Femoral neck changes, is it in coxa vara, coxa valga, or coxa breva? As you know, coxa breva has a short neck. Changes on the femoral head, for example, coxa magna or fragmentation. Actually, I had a review article about the shape of the epiphysis and differential diagnosis, and it's an open access. And then the relationship of the greater trochanter and the femoral head. As you know, the tip of the greater trochanter should be at the level of the center of the femoral head. If you need to comment on the relationship of the acetabulum and the femur, Shenton's line, CA angle, center edge angle, false profile that make you look at the anterior coverage, and AP pelvis should be in abduction and internal rotation, and migration of index of primers. We use this for neuromuscular CP, and now people apply it for Berthes. And acetabular protrusion is a kind of relationship of the femur head and acetabular side. Here is a picture of showing the sourcil, Shenton line, teardrop. So we've mentioned that you can do pelvic osteotomy in day 1 or 2. So we've done a few cases that come with bladder exstrophy. They call us from NICU saying there's a baby born with a bladder exstrophy, or sometimes we know this in advance with the intrauterine, with the ultrasound before the delivery. They come with pubic diastasis, and the urology wants to do the reconstruction, and they ask us to help them to close the symphysis. So many ways to do the pelvic osteotomy in bladder exstrophy, and as I said, that needs specific training and special centers, not only for the technique, but also for the perioperative management and service. So too many ways of the cut. Some people do just Salter osteotomy. We'll talk about Salter soon. Some people do 2 cuts, one vertical, one horizontal as a Salter again. And personally, I prefer something in between. So I do an oblique cut from here to the greater sciatic notch. It's very powerful, and it give me all what I need with only 1 cut. Post-operatively, you either keep them in a traction for about 6 weeks. It's very annoying to the NICUs. They don't like the traction. Sometimes we put a pelvic binder. Some people put X-Fix, but X-Fix for older kids when they do the surgery after the age of 2-3 years, but not for babies. Here is an example of one of the cases we've done. In this case, we did actually a Salter osteotomy. It's bilateral, made them able to close. You can see here the symphysis open. It's widely open. Here it looks like triangular. This area has a lot of cartilage. This baby is doing very well. This is my fellow doing one side. And actually, urology publication always recommend doing osteotomy. It's highly recommended, makes it easy for closure. I know it's a standard, but I hear that some centers only do the urology reconstruction without doing osteotomy if they don't have the trained person of doing this osteotomy. Now we'll go to the main things about the pelvic osteotomy. So why we do, or what's the exact pathology that we need to correct. So the acetabulum either maldirected or globally deficient, especially neuromuscular, or deficiency of the anterior wall. Anterior wall deficiency, as you know, it's mainly for hip dysplasia, or posterior wall, or small acetabulum with a big femoral head. And we know this can happen, especially in Berthes disease. Dr. John Wedge in Toronto published in GPO 1997. Again, the pathology can be maldirection, marginal erosion, torsion, hypoplasia, abnormal shape, whatever it is abnormal, and decreased acetabular surface area. And this is what we talk about, the acetabular volume. And there's only one study published 2006 in JPO about the comparison of the acetabulum volume before and after DEGA osteotomy. So we'll talk about why we do the pelvic osteotomy, what's the preoperative assessment, types of pelvic osteotomies, and I'm not going to do hip dysplasia classification today or radiographic assessment. This is what we'll talk about now, and the planning and decision making. So why we do pelvic osteotomy? So as Dr. Muhammad and all the arthroplasty surgeons know that when they get someone with need a total hip replacement, and young adult or early elderly people, 20% of them under the age of 50 are because they had hip dysplasia. So either treated before or not treated before, has residual dysplasia or had a complication. The rest, like very, very big majority of the people who need total hip replacement early on had either Perthes or Skiffy. And that's why the people came out with the science of femoral acetabular impingement. The consequences of untreated Perthes disease can end in spherical hip, but can be incongruence or can be aspherical, either congruence or incongruence, as you see here. So it's either spherical. So the green one is good. It's congruent and spherical. This is the ideal one we need. Or it's incongruent, doesn't fit well inside the acetabulum, but it's still spherical. Or it's aspherical, flattened, but congruent, still fitting the cup. Or it's aspherical and incongruent, and this is the worst one. Why in hip dysplasia they get osteoarthritis? Because they get abnormal loading on the sourcil, and all the weight bearing will be focused in a small area, and that will cause a degeneration. And here is a good picture, which is not true, it's just a Photoshop. So the survival rate of total hip replacement, and maybe Dr. Muhammad will correct me, after DDH is less than cases need total hip replacement after osteoarthritis. That's because they have tendency of dislocation, and especially the cases that more complex, if it's left very highly dislocated, that need a lot of reconstruction, plus too many things, needed a special size of the implants and needed shortening. They have also high risk of sciatic nerve injury, and too many things. I think it's a very, very special topic. There's Dr. Salter. So goals of Salter innominate osteotomy. So Dr. Salter is from Toronto, and we're all proud, and he's just, he was in Sickets. It's 30 minutes from our university here. So when we treat hip dysplasia, it's a very, very important step before we think about the pelvic osteotomy is to get a concentric reduced hip. So we need to do an open reduction. Perfect. Need to make sure the head fits well inside the socket of the acetabulum. Need to make sure it's well secured and stable. Soft tissue, the capsulorrhaphy, after removal of all the obstacles and all the blocks of the reduction, it's like the vulvar fat, ligamentum teres, inverted labrum, the TAL, transverse acetabular ligament, the psoas tendon that can cause hourglass appearance. All these things has to be dealt with. Reduce the hip spherically and concentric and deep and make it stable. Then think about the osteotomy. Osteotomy is a secondary thing. Osteotomy doesn't make the hip reduced. Osteotomy is augmenting the reduction. So the goal of innominate osteotomy is number one, to normalize the acetabular index. And Dr. Salter has mentioned that he can get about 15 to 20 degrees of correction, and most of the people can't really get this number. Also improving the center edge angle to 10 to 15 degrees. And we just did a systematic review looking at the multiple studies talking about Salter. And we found this very, very significant findings that the central edge angle has improved in Salter osteotomy significantly. And by doing all this to minimize the early onset degenerative changes of the hip and avoiding your patient to have total hip replacement in a younger age. So is there any contraindication to Salter osteotomy? Yes. So for Salter osteotomy, we'll talk about the technique now, tends to get anterior coverage more or anterolateral coverage on expense of the posterior coverage. So it's contraindicated for posterior acetabular insufficiency. How do you know that this patient has posterior acetabular insufficiency? Number one, if it's a DDH, not neuromuscular, mostly it's anterior deficiency, so that's fine. But if the patient has any doubt that it can be under syndromic or neuro elements, or cerebral palsy, like the next neuromuscular hip disease, we have to assess carefully to make sure that there is no posterior acetabular insufficiency. Talking about the technique of Salter osteotomy, as you know, the approach will go through the Smith-Peterson approach, and it's modified through the bikini incision. Usually in kids, it's more cosmetic, and it's an oblique incision. You go parallel to the iliac crest in an oblique way. Too many ways to do this, like keep 1 finger breadth, 2 finger breadths, 2 centimeters lateral to it, but don't go on the iliac crest itself. And then you do the dissection, find, protect the lateral cutaneous nerve of the thigh. If you can't find it and you feel safe and you feel like you're not doing anything blind, that's fine, don't waste your time. Get the plane between the sartorius and the tensor fasciae lata down to the rectus. Split the apophyses. When you split the apophyses, 2 ways, either split the apophyses midline, and Dr. Salter used to call this Salter 3 injury. We induce Salter 3 injury of the apophysis, or some people now getting more to do lifting the apophysis from the lateral side as one piece. Actually, I see this as a long-term can make less cosmetic issues for the iliac crest. But there's no significant difference, and feel free to do whatever you're comfortable to do or whatever you're being trained on. Then if you want to do the acetabular, the top of the capsule and do the open reduction, you proceed, reflect the rectus head. Some people do rectus sparing, but you can always reflect the straight head of the rectus. You have the reflected head as well. So you can do tenotomy or reflect both of them. It looks like a Y. When you find both of them, go in supraacetabulum, and then you find the capsule, clean it, made your T-cut. We can have another discussion about how to do the open reduction, but the main goal of this is the osteotomy. So after you do all the subperostal dissection and the inner table, outer table of the iliac crest, this is what we do. We go very carefully towards the sciatic notch, all the stuff, the neurovascular bundle, sciatic nerve, and it's about 13 structures under the greater sciatic notch are here. Go very carefully subperosteum, give very carefully subperosteum both sides. Pass surgically, so Dr. Rang and sick kids also developed the Rang retractors, which is kind of curved retractors, so can pass surgically, so underneath with a good protection. And then you made your cut in a line between anterior superior iliac spine and anterior inferior iliac spine, mainly a straight cut. Once you do the cut, you need to get the reduction or to correct your coverage over the femur head. you use a towel clip or you use any instrument to bring this all down. You're hinging on the symphysis pubis and try to keep the pelvic brim aligned. Don't displace it too much. That actually give you a long-term, very nice pelvic brim from inside. Salter osteotomy is unstable. You need to get the graft. We get the graft from the iliac crest. It's okay to cut the anterior superior iliac spine included in your graft. Some people do the graft in here as a V and put it inside, keeping the anterior superior iliac spine. There's their argument saying that keep the anterior superior iliac spine will make the people happy to have a belt because we feel it, but I don't see any major difference. And then you put the graft and you fix it with a pins. Most of you use the smooth wires because you go through, hair might go through the triradiate cartilage. Dr. Salter and the people in sick kids use the threaded wires. After you're happy with the reduction, happy with the coverage, you get the direction of the coverage anterior and lateral and distal, and this is the direction that you will get, ending in having triangular space for the osteotomy and fixation. Put the patient in a hip spica. Position of the hip spica, also it's negotiable between the people. Again, Dr. Salter position is 30, 30, 30. It's easy when we teach to the residents, easy to remember. 30 degrees of flexion, 30 degrees of abduction, 30 degrees of internal rotation. Do I do this? I don't go exactly 30, 30, 30. I try to get more flexion if it's safe and it's within the safe zone, because most of the parents ask me how to put the baby in a car seat. So I won't try my best to keep them sitting. But again, 30 degrees of abduction is still I do. 30 degrees of internal rotation, sometimes I feel it too much. So it's based on what you see. But for the exams, people who are going to a master's or PhD, it's good to remember numbers. So here is an example of the X-ray. The case has a DDH, had Salter. If you notice here, there is a little bit of step at the brim, which is okay. It's not significant, then it's healed. These are threaded pins, has been removed. The osteotomy on the other side, typically Salter. Pelvic brim looks rounded, very good, especially if it's a female. You know, the DDH in female is higher than in male. So her birth canal will be fine. Immobilization, 6 weeks in spica. This is what I typically do. Some people go less, and removal time and pen usually in 12 weeks. Although to be honest, I almost stopped doing Salter for DDH, and I will tell you why for the next. So how about the long-term results of Salter? This is a study for 30 years showing that the hip has been preserved in this study lasting for more than 30 years. And this can be expected, and you can tell the parents that there are some evidence saying that the hip can be preserved for more than 30 years, which is fine. So there are some, hopefully you get more studies longer term to say how long the hip can be preserved before this patient need a total hip replacement. Hopefully we'll get a 50 years or 60 years study talking about this. We tried to do a study or a systematic review of this. We couldn't find enough studies to have it on the systematic review. Another question, does Salter osteotomy consistently cause retroversion of the acetabulum? Because too many people talk about this, especially people interested in FAI. So was this study saying it doesn't have to be consistently causing acetabular retroversion, especially if it's done in younger age? Here is an example of a case, as you see, If we draw a Helger-Rhineland line, this hip is out, it's dislocated, and there is a significant acetabular dysplasia. Acetabular index is very high. It could be about 50 degrees or more. This side has acetabular dysplasia as well, and the acetabular index is also high, can be 35. As you know, the normal acetabular index is changeable. It changes with the age. So to make it easy, before the age of 1 year, less than 30 degrees is fine. By age of 24 months, it should be 24 degrees. So 24 and 24, and less than 30 under the age of 1 year. And that's an easy way also for residents and people, candidates for exams. I'll show something interesting here. You see this black line here. If anyone can see this black line, we call it the air arthrogram. It's sometimes a sign to show you how big is the head. This is the cartilage. We only see the ossification, but the head is much bigger than this. It shows you how it is congruent and where is the labrum. Just something. We do arthrogram with a dye that give us similar information. So what to do for this case? We did pelvic osteotomy. Actually, I didn't do Salter in this. We did a Dega osteotomy. We'll talk about the technique now, but Dega osteotomy has been done, and the hip, after hip concentric reduction, this is more important to me. And the capsulorrhaphy was done, and the hip was stable. Look at the teardrop, it's nice, well developed, and you get the coverage. This is after healing of the Dega osteotomy. You see the irregularity here. This is because we took the graft from here. I haven't done anything to this hip, just we adjusted in the spica and actually get a very good remodeling just with the spica. And this is something debatable. Another example, if anyone wants to comment on this, this is a 4-year-old, has a cerebral palsy, came to me with a hip dislocation. And as you see, comparing the acetabular index here, this one is dysplastic and it's going high. So it has both secondary acetabular dysplasia and a hip dislocation. Anyone can just write a comment. What do you think the treatment should be? This is a neuromuscular kid and has a cerebral palsy.
We are ready to receive comments on the questions and answers and the chat.
Oh, okay. That's right. Oh, okay. Yeah.
Anyone wants to have a comment on this case?
Any suggestions of the treatment?
Okay, so yeah, I did send an email to
So, as we mentioned, yeah,
yes,
there is
sir,
a comment.
We have comments here. From Dr. Hani Ibrahim, Dega osteotomy. From Dr. Iyas, need open reduction and capsulorrhaphy with pelvic osteotomy. And another comment, you have to add an iliopsoastenotomy. I think this is very, very logistic.
Excellent. So we get very good comments. So in neuromuscular kids, we need to treat two things. We need to treat spasticities. They usually have spasticity, and a spasticity can be treated medically or surgically. So medically with adjusting their spasticity medication, baclofen, or sometimes we send them to take Botox injection, and we'll go from there. If they have residual contractures beyond the spasticity, so this is a surgical thing that we need to treat. As Dr. Ahmed mentioned, iliopsoastenotomy, that's a good option. We do the adductor tenotomy usually, and I don't open. If the patient is ambulatory, I try to preserve adductor brevis and long and magnus. But if the patient non-ambulatory, it's you can do adductor longus, brevis, magnus, and even you can do the gracilis as well. But talking about the open reduction, this category of patient especially if the hip dislocation is less than 75% of migration index of Reimers, you can get out of this by doing pelvic osteotomy and varus derotation osteotomy. It's different in this categories than DDH, that the primary osteotomy here is the femur osteotomy. They get coxa valga, as you see, and they get severe anteversion with the coxa valga. And when you do tenotomy, you will see how easy it's going back to the hip, to the reduction. And also then we add varus osteotomy. You're allowed to get even to 90 degrees of osteotomy. I don't like to go that much, but I go to 100, 110 once I feel happy with the reduction. Then with this secondary dysplasia, I add a Dega osteotomy. Why Dega, not Salter? We just talk about this. Salter only gives you anterior coverage and will add more posterior insufficiency. These kids mostly has posterior insufficiency. We'll talk about Dega technique now, but Dega will give you anterior coverage, posterior coverage. It's very versatile for your coverage. That's why it's a recommended one for neuromuscular. So open reduction is not really recommended unless it's severely dislocated more than 75% of Reimers. And some people now in Boston Children, Harvard, also doing arthrogram. I don't really use it as a standard of care in my cases, but it's kind of makes sense to look if there is any blocks of reduction. Show you what I've done. So what I did is a varus derotation osteotomy. So this X-ray doesn't show you the exact neck shaft angle. Both look like lateral view, but yeah, I did varus derotation osteotomy only. After the adductor tenotomy, hip is reduced. Then if you see here, this is a residual graft for the Dega. Then I did the Dega. I put the coverage anterior posterior. Here is the site of the graft. And this is 2 years after surgery. And this kid is doing fine so far. It's too young to do this surgery, but it is as it is. He came with a dislocation. We've tried to enforce everything. We treat the spasticity medically, put him in a brace, everything, tried to buy time. The reason is these young kids, when you do the surgery, high chance of redislocation because they're growing. I found when I do Dega plus the VDRO, the risk of redislocation is less. Any question about this case? I think we'll move to OR risk of stiffness, or risk of stiffness. Risk of stiffness, I think Dr. Imad means risk of stiffness by doing open reduction, I think. If this is correct, yeah, there is always a risk of stiffness when you do capsularic and open reduction. There is a specific way of augmentation, doesn't have to be super tight, and also physiotherapy has a very important role after.
I have a question, sir, please. I have a question, sir, please.
Yes.
Would you like to do a femoral shortening or just varus derotation osteotomy in such case, sir?
It's a very, very good point. In older kids, now I almost do femoral shortening.
Yes.
And most of them are non-ambulatory, and femoral shortening doesn't affect them, but decrease the tension and decrease the risk of recurrence. Why we do this surgery for non-ambulatory? It's always a question to avoid hip pain in the future. With the study showing it's 90% chance to get a hip pain, and it's miserable. If you look at the parents when they come with these kids in hip pain, it's miserable. They don't sleep. Also, the rate of divorce is 80% in these families. So it's another social aspect. So next osteotomy is we'll talk about the triple osteotomy. So we'll talk about Salter osteotomy first. I think there is a question here by Dr. Ahmed. At any age you can do Dega osteotomy. So dig osteotomy is coming. Dr. Ahmed will just talk about triple. The reason I talk about Salters and triple, then we'll talk about periacetabular guns next, is these are called redirectional osteotomies. So people like to know these names. So it's redirectional osteotomies because you redirect the acetabulum totally around the hip. So that's why we need a concentric reduction first. So, so after people did Salter became popular, although Salter and Pemberton has been published at the same year, 1960s, but Salter became very popular and it's easy. Everyone knows how to do Salter. And then at certain age, symphysis pubis starts to be stiff. And this is our hinge. So people stay doing Salter in the age of 8 or 10 or whatever, and doesn't get the same corrections you used to get in 2. So start to think why, because it's hinging on the symphysis pubis. Symphysis starts to be more stiff now, so we can get the desired correction. So some people thought about either cutting the symphysis, which sounds like not a good idea, and then another people did another cut, another osteotomy, said, okay, how about if we cut the pubic ramus plus the Salter, and we'll see how it will get coverage. It's called the double osteotomy or the dual osteotomy. Didn't work that much, and then people came out with a third cut at the ischium. So in North America they call it ischium. I know in Egypt we used to call it the ischium. So do ischium cut. And there are three cuts for the ischium. So either steel, it's the most famous one, or Le Coeur, the French one, or Tunis. And I will tell you now what's the difference between the three of them. So steel did this cut, and the pubic ramus and the Salter. So it's based on Salter. This is our foundation. Then adding pubic ramus cut, and then adding ischial cut, and then get a very good correction. So that's a good osteotomy, and it's very powerful. And then steel and Le Coeur looks the same. They get the same correction. But Tunis was a German surgeon, although his name is Tunis, but he's not Arabic. So he came out with an idea to do the ischial cut more proximal here, as you see this line. Why is this? There is a very strong ligament, the ischiospinous ligament. When you do the steel cut, it doesn't give you the desired correction. Tunis cut, when he went higher in the ischium, he get a very, very good correction. He can cover up to 25 degrees. What's the main issue was the triple osteotomy? Again, it's all based on the training. This is not something we talk about and you go tomorrow and get a case and do it based on this presentation. No, it needs a training, 3-dimension imagination. So it's a big problem to get retroversion with triple osteotomy. And there's a special technique to avoid this. I use the Shands pen. I do internal rotation first before I get the lateral coverage. It's hard to explain and hard to say, but again, it's something we probably can make some videos or short videos for these special techniques. Again, here's a sawbone showing how to do the cuts. The first cut simply is a Salter cut. Then we extend our incision and dissection. After you release the psoas or whatever, go to the pubic ramus and do the second cut. Some people do a separate incision to do the ischial cut. I do it all through one incision, and it's same. It's same as we described in Salter, Smith-Peterson approach. If it's a younger kid, I use the bikini incision. If it's a bit older, I might use traditional Smith-Peterson approach. And I will tell you now soon when we talk about guns how to get the ischial cut. Here is a study talking about single anterior incision, which is typically what I do, and but they mentioned this for a steel. Indication for the triple osteotomy, it's a symptomatic hip dysplasia, center edge angle of less than 20 degrees, acetabular index more than 40, spherical head, femur head, it's a prerequisite, it should be spherical. Contraindication, tunis, osteoarthritis. You know, tunis has degrees of staging of classification of arthritis, and incongruent hip is contraindication, irreducible hip contraindication. So again, osteotomies will not reduce the hip. Osteotomies augment or make more coverage for a reduced hip. And significant reduced range of motion and stiffness is always not a good thing to do surgery about. Try to do physiotherapy first and try to get more movement. Dangers, so neurovascular injury is very important to avoid. And retroversion, we'll talk about the retroversion, pain and impingement, especially this type of osteotomy needs a fixation. Mostly need screws if the kid is older, and some people use a threaded pins. External rotation deformity of the limb, so can create this, or uncovering the posterior acetabulum, because this is similar to Salter, it gets anterior coverage more. Now we'll talk about the Gans osteotomy, which is more created after we talk about Tunis and Tunis idea, Tunis from Germany, Gans from Switzerland. They're very close. They used to do a lot of workshops and cadaveric things. That's how the idea came. So Gans thought about, what if I do the same idea? So again, remember, we talk about Salter. This is a basic foundation. Then kids get older, symphysis is stiffer, you can't get the same correction. Then people thought about adding another osteotomy, then adding a third osteotomy. That's why I came with the triple. Then Gans said, triple osteotomy is actually very unstable osteotomy. So you cut the whole part of the pelvis here, take it out, cover the head, and then you let these people stay non-weight bearing for about 6 weeks. How about if I leave the posterior column intact and just cut these? It looks too complicated, but it's actually the same idea as the triple. So I'll tell you the difference now. Again, start with Salter, but this time it's incomplete Salter. We'll stop 1 centimeter above the pelvic brim. And then we do the pubic cut, do the ischial cut, high as Tunis, but it's incomplete. So it's not complete ischial cut. And what Gans added is a 4th cut to connect the Salter, incomplete Salter, to the incomplete ischial cut. Is it complicated or? So I think if you think this way about making a foundation based on Salter and then double and then triple, but Gans is just a modification to get the posterior column stay intact, make it stable. These people allowed to start weight bearing, partial weight bearing in about a week, which is a big advantage. Plus, Gans osteotomy can give you a very, very good coverage. It's a beautiful osteotomy when you get training on. So here's after correction. So let's go back before. We get some uncoverage, some dysplasia. After the cut, you get this covered. Plus, your posterior wall of the acetabulum still intact. Again, so bone, how this will be achieved. So from the inner table, do the cut similar to Salter, but incomplete. I don't go all the way. And here's the pelvic brim. I stop just 1 centimeter above. Those are my pubic cut. I do the ischial cut incomplete. Then I connect both of them. And this is the posterior wall stay intact. Same thing from this picture. And this is the pubis. Here's the pubis, ischium, and we'll do the other cut from here. And this is how it looks like from the lateral, posterolateral view. All right. So approach still the same, Smith-Peterson, and mainly I expose from the inner table. get my Salter cut from the inner table. I know some studies now talking about doing this through STOPA approach or modified STOPA, but still I do it the traditional way. Can do rectal sparing or not. When you open the capsule, here is the most medial, inframedial part. This is a part very close to the ischium. So I clean this, I expose this. I find my soft spot here just under the capsule. Make sure you don't have any blood vessels, and go with the cob until I hit the bone from here, which is this one. You need to have a special osteotomes. It's a Gans osteotomes. It's oblique osteotomes, make your life easy. And then once you reach this area under the acetabulum, you make your cut incomplete. Do it in three steps: posterior, anterior, and middle. And again, you did your top one, did the pubic one, and then you connect both of these from the inside. I also use still the Gans osteotome for this. Here's a picture from inside, and after we're done the cuts, put the Steinman pen or Shands. Again, to avoid retroversion, do internal rotation first before you get the lateral anterior coverage. It's very, very tricky and very important technical point. Difference between Tunis and Gans. Tunis complete, leaving the acetabulum unstable. Gans is incomplete. Posterior wall is intact. It's very stable. Another picture. Again, this is all gone. This is stays. Too many in this table, like the differences between the coverage, the hinge, degree of correction. Feel free to take a screenshot of this one, comparing the redirectional osteotomies, that's Salter, triple, and Gans. And then reshaping osteotomies, which is the next thing we're going to talk about. It's Dega and Pemberton. And the salvage, shelf and carry. You can argue with me about the name salvage, because you can do this shelf for non-salvage purposes, but still people go with this classification: redirectional, reshaping, or acetabuloplasty, and salvage. And here are all the differences between them in terms of age, coverage, hinge, degree of correction, and FAI. And for the question, what age is the maximum to do Dega osteotomy? So Dega and Pemberton, the difference between them and Salter is the hinge on the triradiate cartilage. So as long as the triradiate cartilage is open, you can work. I would say triradiate starts to be very stiff after age of 6. You don't get a very good correction after 6. Some people do it at 8. And neuromuscular, sometimes I do it in older kids, because I believe the hinge is different in older neuromuscular kids because they have soft bones. So sometimes I hinge on the soft bone itself to get the desired coverage. But we'll focus on the principles now. It's about the triradiate cartilage. Reshaping osteotomies, redirection. Now we'll move to the next category, which is the reshaping osteotomy. So reshaping, two of them, Pemberton and Dega, and sometimes it's confusing to the trainees to imagine. So same approach, same everything, expose inner or outer table. And remember, when you start Pemberton technique, you start the osteotomy 1 centimeter above the anterior inferior iliac spine. I use the fluoro, and then you do, to remember, number 1, the start is anterior. Number 2, do you cut the outer table? Yes. Do you cut the inner table? Yes. Where to stop? 1 centimeter or 5 millimeters above the triradiate cartilage. So again, ask these questions. Where is the start? Anterior. Do you cut the outer table? Yes. Do you cut the inner table? Yes. To stop where? 1 centimeter or half centimeter above the triradiate cartilage. So if this is a dysplastic acetabulum, you do your cut, then with whatever means, lamina spreader. You do your redirection. Usually it will work by itself. Once you open it, it will redirect and cover the head anterolaterally. Cut the graft, put the graft. In this technique, they showed that the fix was bent. You don't have to. It's a very stable osteotomy. There's another picture, and this is about the Dega osteotomy. Again, we'll ask the question again. Where is the start point? It's lateral, 1 centimeter above the triradiate cartilage, or above the acetabulum. So the start point for Dega is lateral, not anterior. Do we cut the inner table? No. Do we cut the outer table? Yes. Where is the hinge? The triradiate cartilage. There's a lot of argument about this, but we make it easy for the trainees or the younger surgeons. Ask these questions. Where is the start? Outer table, inner table cut, both in Dega and Pemberton, yes. Outer table in Dega, yes. And do I have to, and then where's the stop? The stop is 0.5 millimeter above the triradiate cartilage. If you're able to stop 1 centimeter is better to avoid cracking through the triradiate, but I always go 0.5 millimeter. A lot of modifications for Dega, San Diego, or Pele modification. Just focus on the principles, don't confuse yourself. I almost do Dega now in everything, because I can get whatever I need, anterior coverage, posterior coverage, from one osteotomy, and this is the main osteotomy I use now. And especially with the Pemberton, although they're very similar, but Pemberton, some reports saying, because it's very powerful on the triradiate cartilage, I believe because we cut the outer and inner table, there are some reports of growth arrest of the triradiate cartilage with Pemberton, but I haven't read or heard about any of these happen with the Dega. Again, Dega osteotomy, where the start? Lateral. Pemberton, anterior. Do we cut the outer table? Yes. Pemberton, yes. Do we cut the inner table in Dega? No. Do we cut in the inner table with Pemberton? Yes. Where to stop? Use the fluoro, 0.5 millimeter above the triradiate cartilage. Always aim to this corner. Get your correction. It's very powerful. I can get up to 20, 30 degrees sometimes. Get the graft, same thing. Put the graft in. You can put it anterior. You can put middle. You can put posterior. You get whatever coverage you like to have. And it's very stable. You don't have to fix it. Same thing. Feel free to take a screenshot of this picture so you can get the comparison. Now, the augmentation osteotomies, I intentionally changed the name salvage to augmentation, but the old traditional name is salvage. So number one is Chiari osteotomy. It's very similar to Salter. It's complete cut, but you do it very lower than Salter, just above the anterior inferior X spine, very close to the capsule, because this type of osteotomy to get the coverage of non-cartilaginous bone over the capsule to get augmentation, and then you depend on the metaplasia to create a new cartilage. So here's the cut, here's the coverage. We get the coverage by abducting the femur, and sometimes it's tricky. You need a lot of force to get this coverage done. And then you have to fix it. Mostly in older kids, we fix it with pelvic screws. Shelf augmentation osteotomies, there are too many techniques of shelf. It's the same idea. You need to put some bone above the capsule and depend on the metaplasia between the bone and the capsule. I do this technique. There are too many ways, but this is a technique I do. So I open the hip, go down, clean outer table, clean the capsule. Then I use a burr to make a trough and about 20 degrees oblique. And here's, you can start by multiple drill holes and connect the holes. And then I get the graft from the inner table because it's concave and it fits the hip. And then I put it on the trough. So here's the shape. So get this from the inner table. shape it, usually 3 centimeters by 4 centimeters, and I measure it, make 4 holes in the bone graft, suture it to the graft, to the capsule, sorry, and then get the desired coverage. Make sure you're not too high, you'll get absorption. Make sure you're not too large to get the impingement, and always test the range of motion before you leave the OR. I use this very commonly now in Perthes disease. And Dr. Salter used to say degeneration changes are retarded or just delayed, but not halted. It can happen. So yeah, I'm open to any questions. Here's a very concentric picture of Mo Salah while scoring. Any questions?
We have 2 questions, Professor Waleed.
Can look at the questions.
The first question, where is the axis of rotation of triple osteotomy?
So triple osteotomy, the axis of rotation is around the hip. So if you remember, Dr. Hani, we said we need the concentric hip. In this case, we're not hinging on the symphysis, and we are not hinging on the triradiate. Although we can do it with open triradiate cartilage, but it's a very good question because it's a very, very loose fragment after you do all these 3 cuts, and easy to get mal fixation. Retroversion, this is what we talk about, external rotation, and the people will not like this. You do a good coverage for the hip, and then they will come back without towing. They don't like this. So the axis of rotation, I hope this is the answer of the question. You don't hinge, you hinge on the air. It's all based on your correction. And I would say the axis based on the femur head. How would you fix a triple osteotomy? I fix it with screws, pelvic screws, 4.5 screws or 3.5 based on the age. Yes, please.
Any rule of CT scan?
What's that? How would you fix difference between Dega and San Diego? So it's a good question, but I will tell you they're almost the same. The San Diego just added, they use the Rongier or the Carrison, you know, the Carrison that the spine people use, and they made a complete cut in the sciatic notch and make a complete cut anteriorly. Let's go back and show you on.
On the stairs? So you can go do the stairs once a day?
So you get, if you look here, you get the Carrison and make a cut here, and get the Carrison make, here, in this picture is good. Take the Carrison, cut the bone completely here, Carrison completely here. So the difference, they make it complete inner outer table anterior, inner outer table posterior, but the middle is only outer table. So they can get better correction. Again, it is the same, but they just added this step and named it a different osteotomy, but it is still Dega. Did you augment your open reduction of the hip with varization of the femur? That's a good question, and it's a big debate. So I will tell you the principle and the standard of care of neuromuscular hips, yes, femur varization and derotation. I personally don't like this for DDH. Why? Especially in younger kids. If you see the kids, they always have, most of them have intone, have femoral anteversion, and it corrects. This is a normal part of development. When I changed it early, I found that that caused a significant change. And I found that this is unnecessary. So I always, when someone asks me the question, and excuse me if you feel this is rude or not, but I would say, they say, why you don't do varus? I say, why you do varus? because I don't see a reason. Like, tell me what's the reason to do varus in a normal anatomy at this age. So the anatomy changes based on the age. You know, the anteversion initially can be 50 degrees at the age of 2, goes down to 15 at 15 years. Any role of CT scan and intraoperative, preoperative, yeah, some people would like to look at the dysplasia, anterior, posterior, or global by CT scan. I tend to do it in specific cases, especially another category you might haven't mentioned is a connective tissue disorder. So hip dysplasia and connective tissue disorder is a very interesting category and very difficult. These are the cases like Down syndrome, Marfan, all these kids, I do a CT scan. And we had actually a review article on GBGS on hip dysplasia and connective tissue disorder. You might find it interesting. Does the capsulorrhaphy affect the stability of the containment of the head after pelvic osteotomy? So Dr. Ahmed, I will tell you. So capsulorrhaphy is, so we're talking about two things. The main purpose of this lecture is the osteotomies, which is secondary on capsulorrhaphy. But if we talk about the stability of the hip and open reduction, capsulorrhaphy is very important, and it's important for the stability, especially in younger kids. Just for the academic point of view, containment usually reserved for birthies. When we say containment, it's a word for birthies, but not for DDH. But just this is something academic. Head after pelvic osteotomy. Dr. A.S., especially when you do femur shortening and high dislocation. So yeah, femur shortening and high dislocation in older kids above age of 6 or 8 sometimes is recommended. And yes, I feel free to do femur shortening if I feel the reduction is tight at any age, if 2 years, 3 years, that's fine, shortening. But varusation, so just to understand me right, varus osteotomy for DDH, in my opinion, is not needed. Shortening, yes, can be needed. So when we say we do the triple things, the varus, shortening, pelvic osteotomy, open reduction capsulorrhaphy, yes, that's accepted. But varus, I have some colleagues doing varus with DDH, but personally, I don't see any reason. Did you face a complication during DEGA, like fracture of the acetabulum? I never had this, Dr. Hani, fortunately, so far. Hopefully I don't. Although Dr. Reggie Hamdi was my mentor in Montreal when I did Miguel Fellowship. He mentioned that almost all the cases get cracking to the triradiate cartilage, but it's non-significant. In shelf osteotomy, does osteolysis of the fragment could happen? Yes. And this is what we said. If you go too high, so I just go just above the edge of the acetabulum. If you go too high chance this will get osteolysis and get absorption. Also, I have the feeling I don't have enough evidence of this. If it's very flexible, if it's not rigid enough and fixed enough, these are the cases that get osteolysis, and you feel bad because you did surgery and then the bone is gone. Sounds like these are all the questions. I'm very glad that
سلام لحضرتك يا فندم من دكتور عماد جابر، بيسلم على حضرتك سلام كتير يعني.
الله يسلمك.
Your dearest friend.
كنا لسه بنتكلم امبارح. What's the maximum age to go with OR for DDH in neglected cases that seek the medical care late? So that's another good question, Dr. A.S. Evidence is very, very weak about this, but talking about the traditional principle and the standards of care, people say bilateral 6 years, unilateral 8 years. I can't find evidence support this, strong evidence. I know in Mansoura, Dr. Khalid Zawlul goes beyond this. My senior colleagues always say it doesn't make sense because the head stayed that long outside of the acetabulum. You know, bring it back in, they get pain, especially after 8 years or so. So they feel this is not their nature. Their nature is the head was out for a long time. but my personal experience is I go up to age of 8. Some cases with pelvic osteotomy ended with hip stiffness. How can we manage them? So I don't see a lot of hip stiffness actually after pelvic osteotomy. So I'll tell you my protocol. So if I do pelvic osteotomy only without capsulorrhaphy, assume that the hip is reduced and stable, just had residual dysplasia and do the hip osteotomy, and the kid is younger than 4, so I put them in a spica for about 4 weeks, and then I start range of motion. If I do all capsulorrhaphy reduction, and I'm worried about the stability, I keep them for 6 weeks. Then what I personally do, I leave them without spica for 2 weeks doing nothing. I don't even send them to physio, just let them recover by their own. Then I start to send them to physio, especially people who are doing hydrotherapy. So let the kids play in the water. To be honest, I've done some cases in Egypt, and when I'm in visits, and they get stiffness. I found it might be difficult. Maybe Dr. Muhammad will correct me. I'm not sure. Difficult to find specialized pediatric physio. And this is what the parents always tell me. So I rarely see this in Canada, but it's unfortunate if it's happened. Yeah. What's your comment regarding Dega-like osteotomy after triradial cartilage fusion hinged on cancellous bone medially? I do this, Dr. Abdullah. I do it for CPE kids, and whatever I get, I accept it. And it hinges on the cancellous bone medially, as you say. Some institutions go for bromistech cast for 6 weeks. I did work in Kuwait in Al Razi Hospital before, and that was the standard of care. 6 weeks in a spica, 6 weeks bromistech cast. And I thought this is a reason of stiffness. I thought that might be one reason of stiffness. I stopped doing the bromistech for 6 weeks, and I have no issues. So yeah, I did this before, but I personally changed and I have no concerns. But to be honest, I have very, very good, well-trained pediatric physiotherapists. So this is a very important point. And that's why these cases has to be done in a full multidisciplinary team or a big institute that has all the services. It's not only about the surgery. You can do a very good technique, but you can't manage all the post-operative things. And as you know, surgeons are busy. We don't do this other stuff. So in case of established stiffness, do you operation on them? So if established stiffness, usually surgery is contraindicated when you have stiffness. So stress on physio and find ways. One patient I've done in Egypt, and he said, I can't find pediatric physio, keeps calling me, and then I said, okay, so what are you looking for the function? He said, عايز البنت تقعد مستربعة. عايزة تقعد مستربعة وهي مش عارفة because of the stiffness. Or she can't go upstairs. So I told him, طب ايه رأيك تقعدها مستربعة، تحاول تقعدها مستربعة كل يوم 5 مرات وتطلعها السلم كل يوم 5 مرات. She's improved. So it's a kind of functional physio. So whatever they want to have, try to train them on as long as you don't have the resources and the facilities.
Excuse me, please, sir. I think the stiffness in this age is a reversible stiffness. It's by training and by exercises in this age, it will be good, I think.
Mostly it will come back.
Yeah.
It's interesting in Kuwait. In Kuwait, when I was there, they used to have certain backgrounds, and there is a certain nationality always stiff post-DDH. And I don't know why. They're always stiff. And to the point, we reached the point saying, oh, when we get this nationality, don't do a very tight capsulorrhaphy because they tend to get stiff. Do you prefer to do medial approach for child less than 1 year all the way to get a bigger or anterior approach after age of 18 months? That's a very good question to ask. So what I usually do is for the medial approach, if I do a case for hip spica, closed reduction tenotomy hip spica, and it's irreducible, I do the medial approach. It's usually between 6 months and 1 year. After 1 year, I like the anterior approach more because I prefer to do a good capsulorrhaphy. As you know, medial approach, you cannot do capsulorrhaphy. You just open the capsule, clean the blocks, and just put them in a spica longer. So instead of 3 months, you put them in 4 months. Some people put them even longer because you don't have capsulorrhaphy. There is a 26% chance these kids will get misshapening of the head of the femur, and it's not a AVN, but it's asymmetric thing. So it's a growth disturbance because we might play with the blood supply. As you know, the medial circumflex femoral artery is running when you do the medial approach. So you have to be very careful with this.
I think we don't have any question. Oh yeah, the last question, sir.
Did you use bioabsorbable K-wires? I never used this, Dr. A.S. I ordered bioabsorbable K-wires for bladder extrophy. So if there's a next case of bladder extrophy, I will try the bioabsorbable K-wires. But honestly, I stopped doing Salter. I would say 90% stopped doing Salter. So I don't use fixation mostly now with Dega.
Yeah.
I think it's enough now. It's about an hour and 10 minutes for pelvic osteotomies. I thought I did a small presentation. I didn't expect this would be expanded, but
presentation, sir.
Hopefully people are awake enough to move to the next subject, which is my favorite subject. And I had the fortunate to do 2 cases in Egypt this summer when I was there. So let me close this and show and open. Recent Coxa-Breva Benha. So I'll have to stop share. And then we'll share again. Can you see the presentation? Sir. Yeah, femur neck lengthening, which is an interesting name. When you say femoral neck lengthening, people will wonder what's going on with the femoral neck. Are you going to do it with Lazarov to lengthen the neck? But it's not really lengthening. It's a special way of osteotomy that ending in femur neck lengthening. So we'll go quickly. This is so I'm facing the window now to the street. It's called the Main Street in front of McMaster University. I'll always see this picture before COVID. And now I'm looking at the Starbucks and the street is nothing. We don't see students now. So the growth of the proximal femur based on 3 main ossification centers and growth plate. There's one here for the proximal femur, there is one here for the greater apophysis, and there is one for the femur neck. All the 3 are important. The shape of the femur neck, I would say, subhanallah, femur neck is very, very interesting. As a neck shaft angle, it's a bone that has to be developed to reach this shape and standardized. Neck shaft angle, special anteversion, special relationship between the head and the greater trochanter. And all of this based on the growth. And it's a balanced growth between all of them. Any disturbance of one of this will misshape the femur and make it in a different way. So again, talking about the secondary ossification centers, as all of you know, primary ossification centers are the big, the diaphyses. Then secondary ossification centers are the ends of the bones. At birth, it's only one piece. At 4 months, start to get the, or 4 to 8 months, you start to see the ossification of the head. 1 year get bigger. You start to see ossification of the GT at the 4 years. And then you get the distinguished, like the most common shape in our mind for the proximal femur by the age of 6 years. It's very interesting. Anyone, for a long time, I didn't think about a way to measure the neck length, the femur neck length, until I found this paper having the measurement of the neck length. So you get this line at the center of the neck, this line at the axis of the shaft, and get this line bisecting the head. And at the center of the head to the center, or to this line bisecting the shaft, this is neck length. And this is how can we have a control of the normal neck length. And that's, again, it's something can be mostly for research purposes. So it's just a small picture showing some interesting findings. Center edge angle, how to measure. Center of the head, vertical line, another angle to the edge of the acetabulum. And it's usually between 25 to 45 degrees. It's a blue line here. And usually people use it after the age of 5. Acetabular index is about 15 degrees. But if you remember in the first talk, we said it changes with the age. So remember these numbers: under 30 degrees before the age of 1, and 24 at the age of 24 months. Again, here is the width of the femur head should be equivalent to a line from the center of the head to the center of the tip, or the tip of the trochanter. And this is the diameter of the head should be equal to this line. And you know how, from the previous picture, how we measure the neck length. Feel free to take screenshots after permission of Dr. Mohammed. Again, if something happened, we can have coxa vara, we can have or coxa magna. Version is another interesting thing. So version increase in the first picture, it's 40 degrees. And this is normal at the younger kids in 2 or 3 years old. And normally it goes back to 15 degrees at the age of 15. So remember 15 at 15. I like this for just teaching purposes. And retroversion can happen. It's about, this one is about minus 30 degrees. And the presentation of kids with antiversion usually come with intone. With retroversion, they come with outtone. Antiversion tends to improve with growth. Retroversion tends to get worse. So when I talk to the family, I tell them the expected natural history. Blood supply of the femur, very important. There is a case that had an infection, caused the growth stopped here, and you see here is the growth stop, continue to grow from the inner side. So you see there is asymmetry caused coxa valga. So coxa valga can happen, not only coxa vara. Depends on where the growth arrest happened. As all of you have a very good experience with DDH, you know, some cases get what they call the Kalamshi classification, AVN type 1, 2, 3, 4. And it's actually, there is also a debate, is it an avian or growth asymmetry? But when they get the growth arrest lateral or medial, laterally they keep doing coxa valga. If it's medial, they get the vara, or if it's just a minor or global, can cause significant shortening of the femur. Again, fracture neck fixed with pins get over lengthening or overgrowth. And at any part of the femur, you can get overgrowth because they get more vascularity. So when we have a coxa breva. So coxa breva means a short femoral neck. Usually happen with AVN or something like Perthes, and affecting the growth of the proximal femur physis. So if the proximal femur physis get affected, so there is no growth of the femur neck. And there will be continuous growth of the greater trochanter. So get a greater trochanteric overgrowth. And as we, is the tip of the greater trochanter supposed to be at the same level of the center of the head. Plus neck length is shortened. If we measure the way we just talked about, compared to the other side, you will see a significant shortening. Plus, we talk about the growth plate that's here. It's still working. It causes the neck to be widened. That's why they get the coxa magna. And coxa magna is usually associated with also wide femoral neck. So get larger head, larger neck, varus, and also trochanteric overgrowth. How this will affect the patient? The abductors are here, get a short lever arm. When they get the short lever arm, they limp. They get a positive Trendelenburg test and positive Trendelenburg gait. When they get the positive Trendelenburg, they start to get fatigue pain, and plus this is abnormal anatomy. This can cause also bone-to-bone impingement, very close to the sternum. So limits their abduction. And get leg length discrepancy, because the shortening will affect the whole limb length. So the etiology can be Perthes disease, DDH, post-infection, post-traumatic tumors, or even can be idiopathic or post-SCFE. They get the diminished longitudinal growth of the femur neck and the relative greater trochanter overgrowth, because it continues to grow, and there is no balance as we talk when we talk about the normal growth. And here is a true case that I will show you the outcomes when we did Morsher. Again, reduce the lever arm, cause limbing, leg length discrepancy, decreased range of motion, and impingement. How they present with pain, limp, and change of their function. They used to play, they used to run, and now they're not able to do this. And there are a lot of hip scores around can measure this with numbers. Clinical examination, Trendelenburg gait, Trendelenburg test, limited range of motion, positive impingement test, because sometimes they get labral tear or degenerative labrum. They have limb length discrepancy, important to measure, and also limb deformity. And it's important to look at the limb deformity. I've seen a very good association, not good, but very high association of this proximal femur deformity was knee valgus. And sometimes it's hidden. And after you do the correction, it becomes more pronounced. Again, we talk about this imaging, stapler side. Make this as your standard when you see the patient, proximal femur side and both. Here's the picture we talk about again. Here's the picture. And get CT or MRI, look at the morphology. Sphericity, as you see here, this is aspherical, it's flat head. So you take a picture of a baby just for fun, but look at the degenerative changes with the CT. And that's a good answer for the question from the last lecture. Sometimes, is there any role for the CT? Yes, can show you the degeneration as well. And the labrum pathology, usually with the MRI arthrogram. You can ask us specifically for MRI arthrogram for labral pathology. Preoperative, again, congruency and no degeneration. Remember only these two things. If it's incongruent and if there is degeneration, this is a contraindication to do the surgery. And then you think about the arthroplasty. Start to do some cases for fun. So 7 years old, bilateral Perthes disease. I like this kid, and he came with limp, and initially had pain, hip, knee pain, and after that was painless. I will tell you with Perthes disease, for me, I send them right away to a very good physiotherapist to maintain the range of motion. That make a huge difference, even with whatever X-ray you would see. But to the point, some people call it physiotherapy containment because you maintain the range of motion. So because he's 7 and he's congruent, he just has some fragmentation. I was worried he will reach the first X-ray you've seen with the trochanteric overgrowth. As we all now understand what can happen is he will get coxa magna, coxa breva, trochanteric overgrowth. And then I said, you know what, we can do a small thing to prevent the trochanteric overgrowth in the future, is just doing episiodesis of the greater trochanter. Stop this, give some balance for him to grow. And there are some options if you'd like to look, but I talk about the option. I did the episiodesis. I do drilling of the growth plate, and also I put screw augmentation. If you look carefully here, you see the screw is not in bone. Why is that? Because this is cartilage. So when I tighten, I feel something. Oh, that's a cartilage. So we see only the ossification here, but the whole greater trochanter is high. So it's even with this age, although with the previous picture, you say, why you do this? He has a very good relationship. He's not. Here, the tip is not at the center of the hip. So he's already started the process, but he's doing fine so far. Case number 2, this is 11-year-old at DDH, had what they call avascular necrosis, had a coxa breva, trochanteric overgrowth, leg length discrepancy 3.5 centimeters. This is just showing you an example. I haven't done Morsher in this case. And I did valgus osteotomy in this case. I always see it looks beautiful valgus with this nice locking proximal femur plate from Synthes. You see restored the tip of the greater trochanter to the center, get some good offset for her, but we didn't restore the neck length. And although she's happy with this, but I was just thinking, why next time I should do something different. Her leg length discrepancy did not correct. So recently she went to Montreal, she did a precise nail. So her leg length discrepancy is corrected. She's very happy now after leg length discrepancy correction. So here's another picture. If you look at the other hip, it's also dysplastic with a very large acetabulum and it needs some work. But she had enough. She gets scoliosis, and I have a good relationship with the parents. And although I've seen them in a different center, then I moved to McMaster, and they keep coming to me. But they went to the state to do the scoliosis because they want to do something non-fusion, which we don't have in our center. Case number 3, 11-year-old, DDH, EVN, but he has a family history of Percy's disease. So some people said this kid might have a Percy's disease on top of DDH, which I'm not sure about this, but because it's family history of Percy's, but he had a strong reason to get EVN after DDH or growth issues, has been treated before by Salter osteotomy. And he had a genovalgum, leg length discrepancy 2.5. So after the case I've done before, and I did the valgus, and I said, if there's any way so I can lengthen the neck. In this kid, I thought about doing this. Then I thought about doing the Morsher osteotomy, which is typically, it's a kind of valgus osteotomy, but we discussed this with Dr. Mustafa Mansoura before. He mentioned a very good point saying, Morsher osteotomy initially by itself doesn't change the neck shaft angle. It's just lengthening osteotomy. If you measure the neck shaft angle before and after, it is the same. Then I started to think, so how can I change the neck shaft angle? Because I don't like this neck shaft angle, it's a burst. And if you look here, there is a sagging rope sign, which is typically typical for Percy's, but you can see it with any AVN. And the reason for this is the overlap for the whole head because it's large. And this is what you see in the lateral view. So it's a very large head. So you can see this is the other border, the posterior border of the head. here. That's why he sees a sagging rope sign. And then yeah, I said let's do Morsher in this case. He has a typical case, trochanteric overgrowth, very, very high, has impingement, has all the typical things. So here's the steps of Morsher. Go quickly, then we'll go in details after. So when you do Morsher, what you want to do is you get initially a pin at the center of the neck, and another pin parallel to it, and another pin at the base of the greater trochanter, and another pin at the middle of the greater trochanter. The idea is all these will do cuts except for this one. And then this piece will be the graft, because this is trochanteric overgrowth. This is an extra piece of bone that we don't need it, but let's use it for something important. So what if I take this piece, it looks nice and quadrangular, add it here to lengthen the neck. Then I cut here and slide the shaft under both of them. And then the greater trochanter will come down to the normal size. Does it make sense? Looks too much. So if you look here, I put my pins a little bit more oblique because I wanted to get valgus. So this is not the initial Morsher. This is a kind of modification we've done to Morsher to add more valgus, especially when they have coxa bar. Any question before we move? There are a couple of questions. Are there any role for 8-plate? Yes, you can do 8-plate, but I found Dr. Hani, the screws for epiphysiodesis are very percutaneous, like it's a 2mm incision. In case of coxa breva, can we do distal transposition of the greater trochanter to improve the abductor function and femoral lengthening for limb length discrepancy? Yes, we can do. But and we will talk about this soon, but I found that when Morsher can do everything in one surgery, and this is what we will go through. So I bought the pens a little bit in
I
a
have
direction.
a question, sir, please.
Yes, sir.
Do you take, sir, any precautions to avoid the AVN in this osteotomy?
Yes. So I'll be very careful at this area when I go with osteotomy at the piriformis fossa. So when I use the saw to cut, and here just very gentle with the osteotome, we call it love tab in our center. Just a love tab. Ask the fellow, say love tab, no divorce tabbing, just a little bit. So yeah, so after we did these things, see the screws are quite a little bit higher. It's better to have it a little bit lower, but again, we did the cut oblique so I can get valgus. This is a modification of Morsher, and here's a piece from the greater trochanter we talk about. We attach it here to lengthen the neck. This piece was here. All this is lengthening, and the greater trochanter reattach it again. The tip of the greater trochanter at the center, almost, like it's not perfect, but yeah, it's not bad. This kid, honestly, was in a wheelchair from pain. Now he's walking. He's the happiest kid. He get 1.5 centimeter of lengthening. He was 2.5. So he has 1 centimeter of shortening now. So that's the answer for the question. Can we do trochanteric transfer? Then we do femur lengthening. You do femur lengthening with Lazarov or with external fixator or with precise nail. I think it's too much. You can do all with only Morsher. And I'm open for any discussion. This kid, we mentioned that he had a genovalgum, was more pronounced after Morsher, which is something we have to be careful with. What do you think to do distal femur osteotomy proximal tibia? I think for the time I will pass the questions. So did hemiepiphysiodesis medially? He gets the mechanical axis corrected gradually, and he actually had a little bit of overcorrection. His 8 plate has been removed, so maybe 2 months ago. Case number 4, Perthes disease sequelae, 12-year-old, 2 centimeter leg length discrepancy. Same thing. So there is nothing new. We thought about neck lengthening, do some valgus with our modification, and cut the trochanter in 2 pieces. Use one of them as a graft to lengthen the neck, slide the shaft underneath. With this one, we added the circulage wire. She initially had hardware failure. The screws of the GT came out after 4 weeks, and then we added the circulage wire. It's under the abductors, if you see, it's not on the screw. She's doing amazing right now, and we'll talk about the outcomes after. This pre, and this is after. I don't have a recent X-ray, but she's almost 1.5 years or 2 years now, so I should update the presentation. This is another case, 17-year-old, Perthes disease. She had Salter osteotomy. You can tell from the broken K-wire. You see the broken K-wire inside. It will stay 10 years ago. And she had a labral tear, and she had a leg length discrepancy of 3 centimeters. And she came like, look, miserable. And to the point, yeah, someone referred her to me. I said, you know what, she's 17, our maximum age here is 18. And she's been living with this for 10 years. Should I send her to arthroplasty now as a transition until she gets 18, then they can do something? Or then I offered Morsher on her, but because she has a labral tear, we need to do something. Plus, her head is too large. Even when I do Morsher after Salter, I think she will have more impingement. Plus, her leg length discrepancy 3 centimeters. I want to do more valgus. I know her neck shaft angle is reasonable if I just do the neck lengthening, but I wanted to add more valgus for the purpose of get some length. So I have here, fortunately, Dr. Femi Ayani is one of the leaders of hip arthroscopy. I contacted him. So the plan was to bring the patient in, put her in traction intraoperative. He will go with the hip arthroscopy to shave the head to a reasonable size. Usually they don't go for more than 50% of shaving to avoid the fracture. And then I told him, can you repair the labrum? In this case, he's a leader for labral repair and labrum transplantation, but he was laughing. He said, yeah, man, you're giving me the toughest case to repair the labrum. And it was amazing. So he came inside first. He started to shave you. If you see the joint is distracted here, this is because of the traction. He shaved whatever large in the head. And I will show you, this is interesting video for him with, hopefully with his voice, no voice. So he did the diagnostic arthroscopy of the head. Fortunately, so she had some degeneration at the periphery of the head, but the rest of the weight-bearing part of the head was fine for the cartilage. So that encouraged me to proceed. And so here's his diagnostic arthroscopy, found the head. I will show you the soft area of the head, degeneration of the labrum, and keep moving. So this is the weight-bearing part. This is the part that he was going to shave. So soft here, and there's no cartilage. Then I was preparing the fingerprints for the footprints, sorry, for the labral repair. And here is the labrum there. Did the repair with suture anchors. Here's after the labrum repaired. And it was also amazing that, and then he did the osteochondroplasty, shaved all this extra part of the head, coxa magna, using the burr. Don't take too much because the fracture. And then he did capsulorrhaphy, arthroscopic, was very impressive to me. And then after an hour and a half of his work, then he called me to start my my part. So again, about our pens, I start with the central wire and the angle, the desired angle. I want to do a valgus just for modification of morsure. But if you don't want to do valgus, you just go in line with the neck. And the other lines should be, the other pens should be parallel to the same one. And I intentionally did this oblique because I felt like here greater trochanter would be better if I go oblique there, and then I will take care of the graft when I fashion it. When I did the cut, I went a little bit higher here. Again, be careful for the piriformis fossa, for the blood supply. And we do the, remember the love tab, no divorce tab here. This is a lateral, then start to cut from the proximal. The two cuts here, you see the greater trochanter looks in a shape that I would like and had the graft out. Remember the big piece, we'll go backward. This piece is out now. And then we have one more cut here. Then it did the cut, slide, did the valgus, and then fixing the GT on top. And here's one of the recent x-rays. She get 2 centimeters of length. She's very happy. She has no pain. And although the shape of the hip doesn't look perfect, but functionally she's very good. And it's very interesting, these people, although you look at the complexity of the cases, complexity of the treatment, they're very satisfied because the amount of pain that they had before. So now she had her labrum repaired, she had osteochondroplasty, she had morsure, her leg length discrepancy only 1 centimeter now compared to 3. This is one of the cases that I've done in Egypt, just prepared the x-rays, tried to do some editing for the pictures as much as I can. This is a kid who is 8 years old, had a history of septic arthritis hip when she was neonate, ended in this growth disturbance. It's a very typical to what we have, coxa vara, coxa breva, trochanteric overgrowth, and Dr. Ihab Osman, Dr. Khalid and Mansoura Khalid asked me to start to do the morsure with the modification to get the valgus osteotomy, and that was the osteotomy we did that day. And here is most recent X-ray. Dr. Ihab Osman sent it to me, and here is a comparison before and after. Khalid Higazi with Ihab Osman. So the goal of treatment is restoration of normal anatomy of the proximal femur, restoration of limb length, improving biomechanics of the hip, gait, improvement abductor force, and hip range of motion. Surgical techniques that can be done, and this is can answer the question, do you do trochanteric overgrowth can be enough? Yes. So these are the options. You can do trochanteric apophysiodesis to avoid this from happening. You can do valgus osteotomy. It works biomechanically like trochanteric overgrowth because you will tension the abductors. Trochanteric transfer, yes. There is something called relative neck lengthening and versus true neck lengthening. The true neck lengthening is similar to morsure. There are some other ways I will show you. And relative neck lengthening is just a simple technique that can create the neck looks longer, but I don't believe it's a true neck lengthening. So here is valgus osteotomy, similar to what we did. And you do whatever the cut you do, and then you do the valgus. This is a case that typically coxa vara. Simple osteotomy with the greater trochanter or trochanteric transfer, just do wedge and do close and wedge, bring it down, or take it off completely, transfer it down. This is the relative femoral neck lengthening. It's simply they cut the greater trochanter in a long oblique cut and then transfer it down. and then they say we gained this length of the neck. I don't consider this as a true neck lengthening. Then you can do double osteotomy. I found this quite complicated to plan and do it. I feel like much easier to me than this, but it's totally up to you. You can get the same results. This helps you also to get valgus. Morsure, the original morsure doesn't help you to get valgus. You can do double closing wedge, which is quite more complicated. It's kind of Z-shaped cutting and then bring it down. I kind of don't understand this. And then you do 2 cuts and trochanteric transfer, which is a typically Morsure osteotomy with a better description done by Dr. Morsure, who published on this in 1988, which is simply the technique as we talk about. You bought these 4 wires. I bought the center wire first. So start with number 3, but you bought 1, 2, 3, 4. And you do 3 cuts, 1, 2, 3. And then you take this as a graft, you put it there to lengthen the neck, slide the shaft under, and at the end you do the trochanteric transfer. Evidence, intermediate long-term results. This paper published 2019. They have 18 patients, multi-center study of 20 hips, did Morsure, different pathology, Perthes, developmental dysplasia, avascular necrosis, and the median follow-up was 7 years, but some of them had follow-up of 24 years. So it's kind of the best long-term outcome so far. Results that overall patient came with limp. They have been improved. They have good to excellent in 12 patients, fair in 4, bad in 2 patients. Post-operative complications included blade migration in 1 patient and wire breakage in 2 patients. But this is minor complications. The main complications are progression of osteoarthritis happened in 3 patients. 1 operation failed and was converted to total arthroplasty, total hip after 4 years, and 2 hips required total hip replacement in 10 years. So by this type of surgery, we mostly buy time. You will need total hip replacement, of course, but when you buy time ranging from 10 to 24 years, I think that's a big gain before the arthroplasty. Here is the results and conclusion. Morsure requires meticulous preoperative planning and execution, and long-term follow-up study demonstrate Morsure is a safe and predictable procedure for restoration of normal hip anatomy and biomechanics. Outcomes of osteochondroplasty and relative neck lengthening looks very promising, except if you remember, we talk about 2 things, degeneration and congruency. It has to be no degeneration preoperative and it should be congruent. And they mentioned something interesting, as if they do this in patients above the age of 28, they didn't do well. So in summary, we mentioned this, that requires meticulous preoperative planning, and prerequisite for the favorable outcome is congruency and no osteoarthritis. This is a patient just we did, and I'm ready for any questions. And I'm very sorry for the long presentation.
Thank you so much, Professor Waleed, for this very, very interesting talk. We have 2 questions, sir.
The question, sorry. So, Dr. Yes, did you go for head size reduction surgery along with neck osteoplasty in Perthes? I haven't done any head reduction osteotomy, Dr. Yes. I kind of very nervous to do because there's no long-term outcomes. A few centers doing it, Baltimore, Dror Bailey, and I'm just waiting for a few more years. I believe we can achieve the same thing by head osteochondroplasty and changing the biomechanics. I believe biomechanics and the restoration of the normal anatomy of the proximal femur plays a huge role for the outcome. Head reduction osteotomy, to make it look nice, maybe, but the outcomes are not promising so far. And you need to do surgical hip dislocation for this. We do this technique through the lateral approach. In Ottawa and Quebec, they do it with surgical hip dislocation. So when I combine our modification of Marshall plus hip arthroscopy, I found a big advantage than doing surgical hip dislocation. What about hocked plating? Hocked plating, you mean blade plate? Dr. Imad?
Dr. Imad, what do you mean about hooked plate?
Angled plate. How to overcome tight hip abductors.
Yeah.
So when you do the two cuts and shorten the greater trochanter, it doesn't become tight like when you transfer the whole thing. Plus, I do abduction when I bring the greater trochanter transferred distally. I agree sometimes the adductors are tight, preventing this abduction. So in this case, I can do adductor tenotomy with a needle. But I don't think it's a good idea to lengthen or loosen the abductors because you will weaken it more. Yes. There is only one technique described by Dror Bailey in younger kids. So what he does is when he opens the ilium and shortens the bone so it will become loose by itself without touching the abductors.
We have any questions, any other questions to Professor Waleed? I think we have done with questions, sir.
Very good.
احنا هنختم اليوم الجميل ده بحاجة واحدة بس يا دكتور وليد بيه. حديث سيدنا رسول الله صلى الله عليه وسلم: من صنع لكم معروفا فكافئوه، فإن لم تستطيعوا مكافأته فقولوا له جزاك الله خيرا. فإحنا لا نستطيع إن احنا نكافئ حضرتك، احنا كل اللي بنقوله لحضرتك جزاك الله خيرا.
جزاكم مثل
يعني حضرتك يعني بصراحة يوم أكتر من رائع. يعني I'm not a pediatric orthopedic surgeon ولكني استمتعت جدا 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 بالفوكس الرائعة دي يا دكتور وليد بيه. يعني احنا بنشكر حضرتك شكر جزيل على اليوم الرائع والوقت اللي حضرتك قضيته معانا. يعني ربنا يبارك في حضرتك يا فندم.
أنا اللي بشكركم جدا وخاصة بعد ماتش الأهلي بقى. مبروك.
هو الأخبار النتيجة
بالرغم إن أنا إسماعيلاوي بس مبسوط للأهلي.
هو فاز ولا إيه يا فندم؟ طب الحمد لله.
الحمد لله.
ربنا يبارك في حضرتك دكتور وليد بيه. احنا سعدنا والله يعلم الله مدى سعادتنا بوجود حضرتك معانا.
انا اسعد دكتور محمد.
يعني معلش احنا خدنا من وقت حضرتك وانا عارف ان حضرتك في المستشفى دلوقتي. اي ثينك ان شغل دلوقتي في الوقت ده. فاحنا شاكرين افضل حضرتك ونامل ان احنا نشوف حضرتك معانا العديد والعديد من المرات. ربنا يبارك في حضرتك وربنا يجزيك كل خير وربنا ينفع بعلمك يا دكتور وليد بيه.
امين امين. جزاك الله خير يا دكتور محمد.
احنا طبعا في نهايه اليوم الرائع ده بنشكر استاذ دكتور وليد بيه قشطه بروفيسور اوف اورثوبيديك سيرجري بيدياتريك اورثوبيديك سيرجري ماكماستر يونيفرسيتي. بنشكره على الوقت الجميل اللي قضاه معانا ويعني ان شاء الله نشوفه على خير باذن الله تعالى. بكره ان شاء الله احنا ما فيش محاضره في الكورس. شكرا يا دكتور وليد بيه متشكرين لان احنا عندنا بكره ان شاء الله الميت ذا ماستر اللقاء الكبير لجمعيه جراحه العظام المصريه بالاشتراك مع بنها يونيفرسيتي اورثوبيديك ديبارتمنت. هيبقى على البروكسيمال فيمورال اوستيوتوميز او سوري بروكسيمال فيمورال فراكتشرز. وفي 10 حالات اوريدي اتقبلوا من 10 من الزملاء الافاضل. معلش انا قلت اوستيوتوميز لان انا متاثر بالدكتور وليد بيه. الدكتور وليد اثر فينا كتير بصراحه يعني. هو ان شاء الله بكره على البروكسيمال فيمورال فراكتشرز ان شاء الله هيبقى في توك لاستاذنا الكبير استاذ دكتور جمال بيه حسني. طبعا دكتور عادل بيه العدوي هيفتتح اللقاء. في توك رائع لاستاذنا استاذ دكتور عصام الشريف. وهيبقى في توك لمحمد الاشهب ان شاء الله في اللقاء. فهيبقى في 3 توكس وبعد كده هيبقى في عرض ل 10 حالات ومنتظرين حضراتكم معانا عشان التصويت على احسن حاله من الحالات. واحنا كنا مصممين زي ما ان شاء الله في الابلايد كورس هتبقى الحالات مش للسينيور ستاف بس ابدا. الحالات لاي حد من الريزيدنتس او من الجينيور ستاف حب ان هو يعرض حالته. He's very welcome و very appreciated فان شاء الله نشوف حضراتكم بكره باذن الله تعالى. نشكر حضراتكم وتصبحوا على الف خير. متشكرين يا فندم.